So I think it is about 3 o'clock. We'll give it a go and start off. And a really warm welcome. I'm Mark Dornan. I'm a GP and I'm one of the Chief Clinical Informatic Officers for the ICB. And I'm going to be chairing the meeting and then just give you a bit of an introduction. And we're really keen that we're really pleased that you can join us. We are going to tell you a little bit about the purpose of the meeting in just a moment, but we'll just go through a quick few ground rules on the next slide, if that's okay. And as we go through that, we're just trying to make sure that people just try and mute themselves just so that everyone else can hear. We're absolutely happy if you just need to pop off and join us again. No need to alert us in the chat function. We are going to make sure this is recorded, and there will be a link shared. It'll be available on the website, and we'll send an email around. So for those that miss it, hopefully you can tell them it was a really good event and encourage them to watch it. We are really keen, though, that this is interactive. So if you have got questions, please do use the chat function and let us know if there are particular things that you'd like to say. I say we're going to kick off, and I guess our first bit is just to tell you a little bit about what the purpose of the secure data environment is. And often a lot of people I've heard little bits about it, so apologies if there are bits that you've heard of to start with, but we'll just go through from the beginning if that's okay. And as I say, for the detail, if we've missed anything, please use the chat function and we'll come to it as we go. I say it is very much geared towards general practice today, but we're really keen that we can give you an overview of what the secure data environment is, what the benefits are, how far we've implemented it, and most importantly, what it means for you in general practice. As we go through the overview of this programme, as I say, I'm going to start off, but then we've got a few different speakers who will introduce themselves as we go through it. Please, as I say, use the opportunity. We've got a number of experts who are not presenting, who are also available to answer questions if you have got something you were particularly hoping to find out. So, I guess the main slide that we wanted to start with is just showing how funding is coming into the research community. And you can see ourselves in the North Cumbria right at the bottom of the chart, which means that our region has the lowest amount of funding from the research grants available coming into it. That means that there's an income opportunity lost for us as providers. There's also real opportunities for patients that are lost. This was published in the HSJ in June last year. And whilst our region has the worst health outcomes, there are lots of opportunities we think that our patients and our public and our providers could benefit. We know that we've got a diverse population. We know we've got lots of deprivation, high prevalence of illness, and we hope that the secure data environment will give a real opportunity to those that have funding to be able to use that funding to access the data, which we already have, and use that to support research to not only improve our patients' health, but as I say, to improve the economic prosperity of the region as we do more research in our area. This overview, I think, is quite helpful because it just gives you the sort of bare bones of what the secure data environment hopes to achieve. Obviously, if we're looking through the lens of practices today, the primary care teams, we hope will have more of an opportunity for patients that they know perhaps aren't receiving a service that is available mainstream, but might be available through research communities. We're hoping that this gives you real confidence that the data that you have in your primary care records is going to be protected, and we'll explain why we think this is a much safer system than the current process and how this fits both the national model and the legal processes, and we're going to explain a little bit more about the detail of that later on. We hope that this will help you as practices who probably receive lots of different requests and, about becoming research active and requests for you to take part in trials. We're hoping that this enables your data to be used in a way that puts less onus and less work for yourselves. And as I say, we think there's a revenue source that might be helpful for you to pay for that the work that you might need to do, but also to contribute to all the pressures that we have in primary care. Obviously, for our researchers, for our universities and those wider, we hope that this will provide a much more easy access, a better platform. It provides a single point that they can go to try and get approval for whether their research can go ahead, and provides lots of the data sources linked together in one different environment. And as we said before, the public, we hope, will enable to benefit from some services that they can't get on the mainstream. We hope that the public will be really clear that the data is much more transparent about how it's used. And we're actually going to have patients and members of the public involved in some of the decision making and policy setting of the secure data environment, and particularly involved in the decision about whether we do allow that research to happen on this platform or whether we don't. We're going to make it really clear about the opt-out options for our public. And as I say, we hope that the public will welcome this opportunity, that the more research can happen and that they can be more part of it. This is a little bit about then the highest level sort of what a secure data environment is. It is an online cloud-based platform that's hosted by Next. And the idea of this is that it enables our approved and vetted researchers to allow access into the data rather than the data being sent to them. So by bringing researchers into this platform to the data, and that provides a far better secure environment rather than us giving our data to them and them taking copies and the data going away from the NHS. So in this model, the data never leaves the NHS and our researchers are allowed into that cloud access and to be able to do their work within this safe environment. And this is in line with the national movement that was outlined in the Ben Goldacre review around how we make it much more secure for our data through this network of secure data environments to be more secure within the NHS and still allow our research to happen. So we've done a lot of work about how we can create this. And there is a lot of bits that we can unpack, but we wanted to just give you a little bit of information about this. So first of all, we are developing our regional research and database. So that means that we're trying to work out who wants to do what. We're then working around the data flows from the different people that have access to it. So you've got the list there of hospitals, GPs, ambulances, mental health. We hope there'll be others that join that list. As I say, those data flow into the secure data environment. We hope that this will reduce the workload, though, and the complexity for those that have a data controller role, so they don't have to keep reapproving and looking at each of the different individual requests and the data set that's asked. Instead, that we have confidence in the regional system where the public are involved to try and enable a robust decision to be made about whether the research should happen or whether it shouldn't. We talked about then the respecting of confidential data, so we're really hoping that this gives a far more secure platform, as I mentioned earlier. There are a lot of different options that we could use. We are hoping that by allowing this environment, we can explore broader opportunities. But I guess some of the things that we want to be sort of starting to think about is that making sure that this is an opportunity for practices who might well see the benefits of things like AI and algorithms. We hope that this will enable the environment to test and improve the new technologies that are out there. We hear lots about it, but we want to make sure it's been researched and properly safety tested. Obviously, lots of clinical trials that we're all aware of, and we hear different bits and pieces of different ones. The idea of this is that we'll have a secure data access committee that will consider each of those different approaches and make sure that we've got a secure way of considering them, and only the right ones that have been properly thought through get through. We're obviously really hoping that by looking at these real world cases that there will be a real improvement in the safety and the cost effectiveness of what we do. So we're hoping there will be a real world application in our region from the research that happens. Population health, a lot of work has been talked about in terms of trying to look at the big population of our region and trying to think about how we can improve the whole population, and obviously lots around the health system research as well about how we can evaluate the services that we offer in the NHS, how we can plan better and how we can improve. So those are some of the things that we hope that this will be used for. I'm going to hand over at this point to Mark, who's going to then give us a bit more of detail and an update of where we've got to with the programme. As I said, Mark Walsh is the programme lead. Over to you, Mark, if that's all right.
Thank you, Mark. Thanks, everybody. Welcome to the presentation. Just picking up from Mark, I'm just going to give a brief overview of what the work we've been doing over the last couple of years and really up to where we are now. The SD program is wide-ranging. It includes multiple elements. We've got a big public patient engagement exercise, communications, information governance, as well as technical and data. We are part of an NHS England program, as Mark said, so we have to work to national standards, including for data security and for confidentiality. A lot of the work we've done is to standardise processes and documentation, including information governance documentation, so that we have an agreed regional suite for approval, obviously removing a lot of the kind of duplication and different versions of different documentation. Since October, we've been engaging with all 11 NHS trusts in the region to help prepare them for kind of providing regular data flows into the SDE. This involved extensive review of documentation by the trusts. Obviously, they need to get assurance around security, confidentiality, etc. And that work's ongoing. But we're now at the point where we think the first trusts, or we expect the first trusts, will be ready to proceed and start flowing data in the coming month or two. And then we'll kind of continue to work with all the rest of the remaining trusts just to get to that point as well. We've also been working for the last 2 years since we got national status to be an SDE. We've been working with a lot of people across primary care. We know from previous work that we've done on programs such as the Great North Care Record that we do need a high level of engagement in order to succeed. We've been getting advice, guidance and consulting with GPs and representatives from primary care since the programme was funded. We've been speaking to them about things like kind of having a cooling off period for when projects are proposed to allow kind of input into where that project should go ahead from a primary care perspective, which we've implemented. How they feel about kind of public members being part of the governance structure we've got in place. And as Mark's mentioned, we have got public membership throughout our governance, as well as a dedicated public members group. And also how they'd like to see the Data Access Committee operate, which is the single point of approval for projects. I'm really pleased to say that we have GP representation on that group, namely Dr. Gareth Coakley, a Cumbria GP, and one of the ICB GPs. And Gareth will work with his colleagues who will step in whenever Gareth can't attend. So we think we have got very good representation from across the region and across different sectors of the region for that group. And my colleague Hills Poole will speak more about that later in the presentation. In terms of the trust engagement, obviously we wanted to work with the GPs in parallel. We had the collective action, so we paused our engagement around that. But now we're kind of ready to kind of re-engage and start that engagement exercise. And we're looking to come out to primary care representatives to discuss the programme and ultimately ask for data sharing agreements to be signed to allow data to flow behind this. We're aware that people will have lots of questions, and we're really here to begin those conversations and start to answer those questions, but we will be coming out on a kind of more localised level to follow up, and I'm sure there'll be a lot of kind of questions which we'll hand in through kind of this route and through those and ongoing. We're also looking to work with 4 GP pilots just initially. We've got 2 already confirmed. The pilots, we want to help test our processes and our communications around what we're doing, particularly kind of focusing on kind of their practices and their patients, as well as understand the impacts on practice time and resource, which we do expect that to be minimal, but we really want to kind of evidence-base that. When a practice has agreed to progress, we anticipate all of the data work will be done by the Commission and Support Unit next, just kind of utilising kind of background processes they already carry out to kind of flow data. But again, we just want to kind of test and evidence that, and again, just look at the impact on practice resource. So just thinking back to kind of opportunities, and kind of Mark's touched on a range of these. Within NENC, we have a range of data and the ability to link data, which brings really unique opportunities for the region and makes us an attractive region for research. And that'll bring kind of new treatments, innovations, and economic benefits as well. We can now use the SDE for service planning and improvements as well as research. And this is something where service improvements in terms of where we may have struggled previously to get the access to the data needed. We'll have increased opportunities to lead and partner in grant proposals, recognising the earlier slide Mark showed about the disparities across regions in terms of national funding, particularly for research and grants available, and the fact the North East and North Cumbria is kind of very much kind of at the bottom of that kind of table. And obviously, we really want to kind of start shifting it up and getting the region recognised as a place to go for research, and to have kind of grant funding flowing as part of that. So I'll hand over to my colleague Hills Pools now, who will take you through the final part of the presentation.
Hi everybody. Let me go on to the next one. So we have a data access committee, which is part of the governance of the platform itself. We've recruited people earlier this year and been working with them to induct them into the programme so they understand what the SDE is all about, how it works in the background, the technical platform that the data sits in, and have been providing training on that. They've also worked through a test project using imaging data as their first kind of understanding of the data access forms that are completed when people want to come and use the SDE. Our DAC is chaired by Ian Campbell, who's a retired pharmacist, and he's Regional Ethics Chair for our Regional Ethics Committee. The roles across the DAC are spread across our region, across our ICS, and they have different specialities that underpin them and give them expertise and help them to ensure that when we use data for different projects, that we've considered all of the legal and ethical kind of considerations for those requests. From an IG perspective, there are a number of ways that we are keeping the data safe. Patient details are either removed completely, so the data is anonymized, or we pseudonymize the data, so we will take identifiers and replace them with a different key or a different kind of set of random numbers that enable data to be linked but not to be identifiable. So the data, when it's seen by a researcher in a workspace, bears no resemblance to the identifiable data that was in the initial data set. The data never leaves the SDE, and it's all hosted by Next, as Mark's already said. We've been through the Confidentiality Advisory Group, so CAG, who work on behalf of the Health Research Authority, and we've also got Research Ethics Committee approval to generate our research database, which we can also now use for non-research purposes as well. This is the mechanism that's used by other SDEs across the country as the lawful basis to enable that data to come together and be held. And there are a strict set of kind of criteria that we meet in order to achieve those kind of approvals. We've worked closely with IG leads across the region and also across the national programme. And locally within NENC, we've been working with DPOs across primary care to ensure they're happy with the approach. We've been engaging with them for about 18 months now, so that in the background they're cited on everything that's developed within the SDE, how it functions, and they're very much part of the assurance process. So this means that we have a single data controller for the SDE, so the data is shared into the SDE. Once it's in the SDE itself, it's under the controllership of the NENC ICB. So the ICB itself is liable for the data within the SDE and the use of the data after that point. All of the IG paperwork and contracts are in place. So we have a contract between the ICB and Next to provide the SDE environment and for them to undertake the processing. We have data sharing agreements in draft for primary care for the SDE, and we also have them in place for the provider trusts across NENC. So the ISG, the Information Sharing Gateway, is where the information sharing agreement is hosted, and the data processing agreement will come out as a separate contract. Everything that we've done complies with the law and also complies with GMC guidance on the sharing of confidential information. In order for us to get the right legal approval in place, particularly to set aside something called common law, we went to CAG and we have their approval. So that's our legal route to enable us to do what we're doing within the SDE. in terms of patient and public involvement, part of what's really critical from a confidentiality advisory group, so CAG perspective, is how we've talked to and communicated to our public about what we're doing with their data. So for us, it's been much more than just a tick box exercise. We've got a kind of public thread that weaves through everything that we've done. So we have 16 public members who are part and parcel of the SDE team, if you like. Our public members have been working with us for over 18 months now. They advise us on the development of the street survey, which we'll come to in a second. They kind of check and validate our publication materials. We sense check everything that we develop, and that will be shared kind of later on as part of the comms pack for the SDE. All of our public information goes through that group for them to be able to sense check whether or not what we're saying actually is understandable if you're not working in the program. In terms of the public evaluation group, they are a group of members, and they will help to assure that we have considered the public view of the use of the data, so whether it's in their public interest. They keep us, they will have the ability to make a recommendation as to whether or not a project is in the public interest from their perspective. In terms of the street survey, we contacted more than 1,800 members of the public across North East and North Cumbria in a series of street surveys. Analysis was done on the national data opt-out to show the priority target groups and their concerns, so that the focus work that's done within that kind of area is targeted to that group. Shall I pause for a second? I can see some stuff in the chat, but it's hard to do the slides and see the chat.
Hills, the question that was in the chat was asking about small data sets, and Paul has asked, where numbers of patients in the data set are very small, are there safeguards to prevent data becoming identifiably unintentionally?
Yeah, so we use small number suppression. So that's part and parcel of what happens with the approval route through the Data Access Committee. So in particular, so when a researcher or somebody wants to come and use the SDE, they have to define the data set and the specification they want to use. And within that, we'll be able to see whether or not that cohort of individuals is a small one, at which point we will use either small number suppression. So we can either add noise to the data set to make the data set appear bigger, or we can minimize the data that they see in order to ensure that what they see is not, reduces the risk of re-identification. So things like rare disease registries, that kind of thing. So that's already been kind of considered and is a robust part of the DAC evaluation.
Thanks very much, Hills. And just checking, Paul, was there any other questions you did? Catherine's answer in the chat function answer your question. Do feel free to speak if that would be helpful, but otherwise, hopefully we've answered your two questions. Back to you, Hills.
I'll sit forward one. So the regional communications campaign, we've developed a set of materials with our public members, as we talked about before. Funds within the SD will cover regionally the advertising online and offline channels such as social media, adverts, radio, music streams, leaflet drops, posters, that kind of stuff. So that will be standardized material that will be available across the system. So whether the messaging then becomes consistent, whether you're sitting in primary care or whether you're in an outpatient clinic in one of the provider organisations. And the GP toolkit, I think we mentioned briefly at the beginning, will be part of what comes out to primary care. In terms of next steps, as Mark talked about right at the beginning, the pilots are starting hopefully. And as we work through the pilots, we'll start to learn and gather intelligence about the best way to undertake onboarding of GP practices, of GP data flows into the SDE. So the regional engagement will start in June with a view to practices agreeing to participate and flow data after that point. And if any practices are interested, please get in touch. There's contact details on the slide. And I will Does someone want to take control?
That's fine, Hales. We'll perhaps stop sharing the slides at the moment, and we'll just check if there are any other particular people that would like to put their hand up. We are absolutely happy to having physical questions and people speaking, but also if you prefer just to put them in the chat function, that's absolutely fine. I know that there have been some questions that have been submitted before that Catherine had. I don't know, Catherine, if you wanted to just mention any of the thoughts that have come up elsewhere that we may want to just mention. Hopefully we've covered most of them as we've gone through the talk, but if there are any other questions that you've heard of, please do let us know as well.
Yeah, I mean, we're doing some focus groups at the moment, and the question that keeps coming up with the public is around the anonymisation of data, and there's certainly a lot of the feedback that we're getting is that generally sort of people are okay, but it's on these sort of terms and conditions. So I think certainly the anonymisation or pseudonymisation is stuff that the public are really sort of talking about quite a lot. And I mean, the focus groups have been very interesting, just hearing what people think about this sort of thing. I know that Paul mentioned as well about at-risk groups. So what we've done with the PPIE programme, it's kind of like, it's a bit like an onion, like unpeeling an onion, really. There's lots and lots of layers to it. So we've kind of gone with the broader ask everybody who, you know, I mean, with the street surveys, and then we're kind of drilling down into more and more. So we're finding the groups of people who were more concerned. So we've got some interesting stats on the demographics around that. And then that's enabling us to kind of explore that further. So we're kind of digging into the patient and public involvement work more and more as the kind of programme progresses. So at-risk groups and seldom heard groups are actually really important part of that, but we've got to kind of go through the process that we're going through to get to them. So I'm the comms lead for the programme, so I'm not on the PPIE, but for me, the comms to the at-risk groups or seldom heard groups is engagement and involvement work. So we're working on developing that at the moment. But again, like I say, we're kind of going through this process. And actually a lot of that's about sort of tailoring the sort of the materials that we've done across the region. It's putting things in different languages, it's putting things in easy read, getting things put into British Sign Language and stuff like that. So there's lots of ways, and this is where we've got to kind of really do the nuanced comms work as well. So and again, it comes back to what Hills was saying. A lot of we won't get the legal basis for doing the work that we're going to do unless we engage with all of these different groups of people. So I mean, it's the right thing to do, so we'll be doing it anyway, but also it's really important that we are going out, and obviously we don't want, you know, I mean, people need to make informed decisions about opting out, because obviously there is an opt-out option, and it is really just about providing information that's factual so people can understand what this is about. Is it for me? From the feedback that we've done, what most people want to know is what are the benefits and how do you keep my information safe? So they've been the kind of two sort of really key messages that we're putting out in the comms. So we are producing a GP toolkit as well, so I'm just working on that at the moment, and we'll test it with these initial practices and see what feedback we get, and then obviously if we've got to amend the regional materials, then we will do that. But yeah, so I'll have to talk about comms. I'll fill the next half hour if you like.
That's really helpful. I can't see any other questions in the chat function. I can't see any other hands up, unless there's anything else that people feel that we've missed. Now is your moment. If not, we'll say a huge thank you for everyone joining. We hope that you feel free to ask us questions that you think of later on. As I say, we will be sharing the link. We will be very keen for people to sort of contact us if they do have any questions, if you can forward the recording when you get it to other people as well. And hopefully that will be helpful for others as we gradually go through this journey. We can just end with sharing the last slide where we've got
we've got a question just popped in from Tom about signing up as a GP pilot, as a pilot practice.
Absolutely. Mark, Mark, do you want to just mention that one? And then I was just going to mention that once we've taken any last questions, we'll just put the QR code and the chat link on our screen, just for those that can then go on and see the website link as well, where a lot of the information's stored. But Mark, do you want to just answer that question?
Yeah. So with the practice, ultimately what they'd need to sign is the data sharing agreement, which I know most of the practices would have been through that process for the Great North Care Record Programme. And in a similar way, the data sharing agreement is on the information sharing gateway, a kind of a digital tool, just to avoid having lots of pieces of paper kind of flying around. And so the data sharing agreement's actually there now. It's ready to sign. We, as part of the kind of engagement, will give instructions on how that will be kind of signed. There will be some flags, if you like, to just kind of to kind of tick whether it's kind of EMIS or TPP in terms of within the clinical system, but ultimately it's just kind of giving the agreement technically for the system to flow the data through the relevant clinical system, and then literally signing the data sharing agreement. In effect, then we can start to kind of flow the data behind that. And that's what we'll just be checking that process with the pilots. As I said, we think it'll be quite minimal involvement from the practices. A lot of the work is really just starting to get the practices to a position where they're happy with what we're doing, they're comfortable with all the security and everything in place, patient confidentiality, and then just going through the kind of process of kind of signing the relevant documentation, and that then allows the data to flow in the background. So in a nutshell, kind of that's what we do.
Fantastic, and thanks very much for that comment, Paul. Absolutely, they did some really fab comms work. I totally agree, and there's been lots of engagement around the region. So, any final questions? Anything else that people wanted to mention? Hopefully, you've seen the links in the chat function as well. And if there's no further questions, we'll say thank you, and we'll stop there. Thanks very much for joining, everyone. Enjoy the sunshine.